as the topic is dysfunctional mitochondria and how we are going to correct it. Uh, it's it. So what is this Imeglimin? And we need to remember that before all that, good afternoon everybody. My name is Dr. Harini Reddy and I'm a practicing consultant at Apollo Hospital. I know that I'm not belonging to this cardiologist crowd, but I would like to thank the organizers for giving me this opportunity to talk today. And it's a privilege to attend this conference. And let me quickly walk through today's agenda. And we'll start with the burden of diabetes in India and why it's such a pressing health challenge. Then we'll explore the core defects driving the disease, the so-called triumvirate. Next, we'll be zooming into the mitochondria and see what is happening and why do they stop functioning properly, as this PowerPoint did as a couple of minutes ago. And now this is going to be the stage for this new molecule, Imeglimin, which is a simple but beautiful molecule. And this has been present in the market for only a couple of years. And so it is a research molecule dated 2 decades back. But because it was not backed by any multinational giant, it doesn't belong to any country, you can't expect much hype behind this molecule. So we will be looking at the clinical evidence later to support this molecule and see how it is working at the cellular level, and then we'll see how it is comparing to the anti-diabetics. Then finally, key takeaway points and in practice. So basically that's our roadmap where we'll be talking about the big picture, then the molecular level, and finally the patient considerations. So if you see that this is the NCD risk factor collaboration. I know this slides can be changed, but here I wanted to tell you that India is the topper among the world right now. It is wearing the crown, nothing we should be proud of. And China is standing quite behind us, and also not in the number of treated of diabetes mellitus, but even in the untreated diabetes mellitus patients. So while share this slide with a room of cardiologists, I need to tell you that 7 in 10 patients of the diabetes died because of the cardiovascular causes. And even if you see the CUP study in Chennai, they said that diabetes and heart disease, there was a very close association. And if at all you want the future burden of the heart disease to decrease in India properly, please take care of diabetes in advance. And remember that every undetected diabetic represents a higher chance of future heart attacks and strokes. So I know you are the front leaders, cardiologists who are fighting the heart disease, but please try to take care of the patient at the early level. So these are the 3 key points where the diabetes starts. If you see that, as you already know that the pancreas, the beta cell dysfunction is there. Next is the muscle where the insulin resistance is there, and finally the gluconeogenesis liver. If you look at it, 3 different specialities, no way connection. But if you see this thread, yes, it is running through all this. There is a common denominator, and this denominator is nothing but the mitochondria. At the level of mitochondria, dysfunction is happening, and you can say that this is a missing piece. So what we need to look is we need to dive into the cell and look into the mitochondria, which is nothing but the energy factory of the body. So this is the mitochondria with its inner mitochondrial membrane. So I know that its molecular mechanism is complex, but you just need to remember that it's like a factory, a power plant where conveyor belt is taking the coal away, and normally in the normal cell, this coal is burnt, energy, electricity is produced in the form of ATP that is very crucial for the cell to work. So what happens in a diabetic cell? This mitochondrial function isn't happening, as a result of which the coal doesn't move over the conveyor belt stops. This ATP is not generated. Many, in fact, smoke fumes are produced, causing nothing but the reactive oxygen species and leading to the cell death. So what are these guys doing over here? So these are nothing but the Imeglimin molecules. So you can think that Imeglimin molecule enters into this inner mitochondrial membrane and tries to be like a technician who helps run the conveyor belt smoothly. As a result of which, the power plant again restarts in a smoother fashion. So this is what we are talking about. So diabetes and its relation with mitochondria. Ultimately, you need to remember that metformin also acts at this inner mitochondrial membrane, but it is very different from that of the imeglimin. So I understand that mitochondria is fine, but what ultimately bigger picture, what happens to the cell? You know that cells are not running in isolation. So you have this robot vacuum available. If its power is good, it is going to clean properly. But if at all the battery is low, what happens? The robot vacuum gets stuck, debris gets accumulated. So this is what is nothing but the mitochondrial damage. Ultimately, debris gets piled up in the cell, that is leading to a dysfunction in the cell. So now comes the role of the imeglimin. So this is the new oral drug, the first in class at addressing this triumvirate. So it corrects this mitochondrial dysfunction, improves the beta cell mass, improves the insulin secretion, improves the insulin resistance. As of now, no molecule can boast that it is going to act on all these levels. So if you see that this is, you can say that this is dissimilar twins, right? Similar structure to metformin, but working very differently. And this is a tabular form trying to give you a little bit perspective of how imeglimin and metformin are similar and dissimilar. If you see that metformin is acting at complex 1, non-competitive inhibition, but imeglimin is not only acting at complex 1, but is mainly acting on complex 3 trying to restore function. So what does that mean? So it is not only causing insulin secretion, which is not happening in metformin, but all other metabolic parameters are corrected. So what is this metabolic inflation? So now you know that you have cars, hybrid cars, race cars, petrol cars, diesel cars. So even our cells run on different fuels. So you know what happens if a petrol car gets the diesel in the fuel tank? That is what is happening. Heart usually runs on free fatty acids, nothing but the diesel. And if you see the brain runs on glucose, muscle takes both the fuel, either the glucose or the free fatty acids. So what happens in a normal cell, this flexibility, I have a hybrid car, I can convert it into a diesel and the petrol, I don't have any problem filling up the tank. But in diabetes, this switching is lost, the flexibility is lost as a result of which. If diesel is poured in the petrol engine, what happens? Engine breakdowns. That is what is happening in the beta cells of the pancreas, where free fatty acids are accumulating, causing generation of the beta cell dysfunction and ultimately beta cell failure. So this is the dry topic that I have tried to present you in analogy to the car engine. So these are various molecular mechanisms that will be of interest to the researchers and the biochemistry. So this is in depth a little bit about imeglimin and metformin. Remember that metformin primary target is the liver, but imeglimin acts on all 3 triads: pancreas, liver and muscle. In fact, imeglimin has also emerging evidence that it is acting on the kidneys and also on the heart. We'll come to that later on. So coming to the clinical evidence, yes, before you want to use it, what is the evidence supporting it? So this was the first trials published in Japan, done in Japan and approved in Japan compared to the rest of the countries, and later Indy time study was conducted. It's a simple study, observational study. What was proven? To summarize, this study said that imeglimin is very safe across the entire spectrum of diabetes except the end-stage kidney disease, where please use a decreased dose. And it is having a good HbA1c reduction of even up to 1% compared to the other anti-diabetic agents as of now. And this efficacy starts within 2 to 4 weeks of onset, and it is sustained. And it can be added to as an add-on, or it can be used as a monotherapy. So these are the other studies, and this was one study trying to show the timing range, because these days everybody is using the CGM. We have understood that only checking fasting, post-lunch and HbA1c is not of a very good idea. So CGM is used time in range, and a very good time in range was seen on imeglimin. And this is a graph that is supporting that evidence.
And this was an article, meta-analysis of 8 studies trying to support that the safety profile of the Imeglimin. It is equivalent to a patient taking placebo. If you have seen that placebo-like side effects for many of your patients, and that is the same side effect profile on using this Imeglimin. So ultimately, to summarize, Imeglimin is acting through the mitochondrial inner membrane and targeting the various organs. So coming to this cardiology, as we will be talking morely focusing on that. So what is this autophagy and mitophagy that is being talked about in the heart disease? So you know that mitochondrial balance is the one that is responsible for a healthy heart. So you know that a heart has a lot of mitochondria. It needs to, because it is pumping throughout the day, 24 hours, 365 days throughout your lifespan. Even 1 second matters. So mitochondria are the powerhouses. So think of it as a smartphone with everlasting battery. So autophagy, you can think of it like a car engine, where you go to the regular maintenance servicing centers to repair your car, and finally if your engine dies down, you don't want to change the car, please get a new engine. That is what is happening even in the cellular level, where autophagy and mitophagy is happening, and ultimately it is happening even at a physiological level, but the balance should be there. Why is it important? Because many of the acute and chronic cardiac conditions, this balance is disrupted. If you're talking about coronary artery disease, after the reperfusion injury, this is the mechanism that is responsible for the injury. So as of now, evidence-based, we don't have any strong CVOT trial. Don't even expect it, because FDA requires very stringent guidelines. And the main thing, it's the monetary backup, billions of dollars, which is not possible for this simple, humble molecule. But clinical evidence, as you know that many of the drugs used in India don't have an FDA backup, like Voglibose, many of the TB drugs. We are the pioneers. So Asian countries can use this based on the clinical evidences that are present as of now. So in acute cardiac conditions and chronic cardiac conditions, theoretically, yes, heart failure, even with reduced ejection fraction, diabetic related cardiomyopathy, even MI, but be careful, don't use it in acute MI as of now, because there is no evidence backing it up. And so what about liver? Again, why this liver is coming when I'm talking about the heart? As you have known, right now emerging research has shown that non-alcoholic fatty liver disease is one of the major player in the cardiac disease generation. So this liver is going to send lot of signals like a regime change. It wants a regime change that is happening right now worldwide. So it is going to send lot of inflammatory signals. It is going to cause fibrosis in the heart muscle. And again, this is mediated by the metabolic dysfunction due to the mitochondrial dysfunction. So this is what to do when you are sitting across the table, how much to write, when to write. That is the kinetic and dynamic properties of the Imeglimin. So I start with 1 gram BD dose. In all the individuals, you can use it. Elderly to treatment naive, insulin patients, metformin patients, SGLT2, GLP-1s. There is no you can't add Imeglimin because metformin is there. You can't Imeglimin because the patient is on insulin. And please remember that there is no drug-drug interaction, no food interaction. Only if EGFR is going below 45, just decrease, take the tablet in half. There is 500 mg BD is available, and mild side effects are observed, no major side effects. So this is the lactic acidosis that metabolic metformin is usually going to cause in a heart patient. That is rarely seen with Imeglimin because of this mechanism of action, because it acts later in the complex 3 in the respiratory chain. And any advantage for the kidney, as Bipin sir previously pointed out, that SGLT2 inhibitors had lot of evidence backing up the renal protection. So what about this? Small studies, as obviously you can expect, but yes, definitely through its role of metabolic restructuring, what does it do? The fibrosis, the inflammation that is occurring in the kidneys are reduced, as a result of which you can stabilize the EGFR and you can offer some renal protection. So these are the studies backing up that. And what about the heart failure? Definitely, there is improvement not only in the glycemic control, but also in the chronic changes that are going to affect the heart muscle in the heart failure. And this is a study performed in Japan. This is a twinkle study. And what did it conclude? That in CKD stages, even 3B, there was a sustained glycemic efficacy of Imeglimin. So you don't need to worry when you have a cardiac patient with eGFR reduced, you can still use this. So what do the Indian guidelines say? Yeah, you can use it, please start it, don't shy away from it. You can start monotherapy, especially even in metformin intolerant patients, start it. As an add-on, you can start it. And if at all you want to start in an end-stage kidney disease, up till 45, use 1 gram, but less than 45, chop the tablet into half. So these are the limitations, as you know, with the various oral antidiabetics and also the injectables. And the side effects are less for this Imeglimin. So as of now, so we are coming to the end of the talk. So please feel free to use this Imeglimin. Even the cardiologist can prescribe it. There is no such limitation, because right now the specialty lines are blurring, and this can be especially used in elderly because very low risk of hypoglycemia, and you can interchange the drug. You can intensify the regime by adding the Imeglimin. So key take home messages are, it's a very new drug, but very under marketed, and as of now it doesn't have any FDA backup. But it does address the root cause of the problem, not only the sugar control, but the entire cardiometabolic renal spectrum. And acute conditions, shy away from it, don't use as of now, but definitely think about it when you're trying to control the diabetes and also other cardiometabolic aspects in your sugar patient, and especially in the preserved ejection fraction. With that, I end my presentation, and any doubts, feel free to ask.